We continue with the next session. My name is Anna Borovechke. I will be the next chair. And let me introduce the first speaker. So this session is about COVID-19 pandemics, lessons learned. And our first speaker is Montse Esquerda Areste, and she comes from Ramon Llull University, and she is a medical doctor and psychologist, specialist in pediatrics, director of the Borja Institute of Bioethics, Universitat Ramon Llull, and pediatrician in St. John of God Lleida Hospital, president of the Ethics Commission of the College of Physicians of Catalonia, corresponding member of the Royal Academy of Medicine of Catalonia. And the title of her talk will be Medicine Changes Fast. Medicine Changes in the Instant, Healthcare Professionals and COVID-19.
So, thank you very much, Anna, for the presentation, and thank you for the invitation. It's difficult to shift to another issue, so we are going to talk about COVID-19. I'm going to try to link all the issues, engineering life and COVID-19. I think it's a bit difficult, but what are the lessons learned or lessons we should learn from COVID-19? Bauer is a sociologist that it's an interesting book, and he say, to be able to understand and answer the questions, the most important questions of our century, we must know some languages. So atoms, bytes, and genes, but he forgot viruses, yes? And now the most important issues and ethical conflicts of our century at this moment has been virus. But there are different languages, but there are some similarities of the ethical conflicts of these different areas. And so I'm going to try to link it. Because COVID-19 arrived fast, in a really fast way. In days, during a weekend, at least in Spain, it was in a weekend that the pandemic arrives. And I borrow this sentence from the book of Joan Didion's book, The Year of the Magical Thinking. It's the beginning with this sentence: life changes fast, life changes in the instant. You sit down to dinner and life, as you know it, ends. I think COVID-19 was really a fast shift paradigm. And I'm not sure if gene editing is going to be another shift paradigm, but I'm not sure it's not going to be so fast. So we could be prepared for it. But this is an interesting book about changes and grief and losing. It's similar to a magical thinking. It's all the changes are linked to this kind of magical thinking around it. Maybe we were aware of human fragility, but few of us were aware of the fragility of our society and the fragility of our medicine and our healthcare systems. So, as Paul Ricoeur said, fragile make us responsible. Could we have been more prepared? In 2005, it's a paper from Kotalik, preparing for a pandemic. Kotalik analyzed the pandemic plans of different countries, yet there was pandemic plans. We don't know where, but there were pandemic plans. And all these areas has been present during the pandemic. The scarcity of human professionals and material resources, the mass vaccination as a part of the solution, but it's necessary to estimate benefits and burdens of the vaccination. The extraordinary demands at the healthcare professionals, and all society and all individuals will be affected by the pandemic. Pointed this point also maybe could be applied in ethics, gene and ethics therapy. This sentence, a pandemic places extraordinary demands on healthcare professionals, and a successful response to a pandemic will greatly depend on their attitudes, skills, and efforts. Because it's an unknown disease with unknown situation. The burden of extraordinary demands on healthcare professionals is a physical burden, cognitive burden, psychological and ethical burden. Physical burden, days and hours of continuous work, working in much more strenuous conditions. Cognitive burden, there are many uncertainties, too much to know, transmission, diagnosis, evolution, complication, treatment. And we have different ways to deal with uncertainty. This is, for example, a picture about the different prescription rates of chloroquine among different countries. For example, with similar situations, in United Kingdom, there's a 10% of prescription rate, but for example, Spain or Italy, 75 or 83% of prescription rate. We deal with uncertainty in a different ways, and we are really drowning with papers, with so much information. From January 2022 to May, 40,000 articles from COVID-19. Yep. But, well, also, yes, next. Also emotional burning. Next, please.
Can you just move the next slide?
Next.
Thank you. Okay.
Next, please. Also, there's a specialization. I'm not sure this name exists, but we change our knowledge, our formation, and also an emotional and an important psychological burden, how many emotions at the same time and moving so fast. Next, please. As a result, it's a dramatic increase in burnout and decrease in life satisfaction in healthcare professionals. At this moment, it's a recent work, 60–80% of healthcare professionals are with burnout. Next. But there's also ethical burden. Next. With multiple and new ethical conflicts. The first of one is the shift of the paradigm in medicine. The other one is working without protection, with a high risk of infection for ourselves and our families, lack of resources, prioritization, fear of future complaints or lawsuits for the decisions made during pandemics, contact with death, people who die quickly, unprepared, alone, without a family, without a goodbye. Abandonment or loss of quality of care of non-COVID patients, specialization, uncertainty, traces, confidentiality, ethics and research, vaccines, children's rights, so many quantity of ethical conflicts. Next, please. I think that healthcare professionals are also second victims of the pandemic. Next. So, lessons learned or lessons we should learn. Next, I think that if you allow me, and Catholic allows me, gene editing therapy places or are going to place also extraordinary demands on healthcare professionals. And also successful response to this kind of new therapy will greatly depend on their attitudes, skills, and efforts. Next. Because we can use what the lessons of COVID-19. First lesson, I think one of the most important one, I know there are two points here, not just one. Don't forget, take care of people, and don't forget asking people for that. Caring is one of the main priorities of our medicine. Scientists work with genes, with cells, in a laboratory. Physician works with people. So physicians are going to work with the failures, with the secondary effects, with the promises. What we are talking about are going to have some side effects. So physicians have to work with that, with people, with a lot of end-of-life decision, a more difficult end-of-life decision with children, with rare disease children and families, genes and persons. We may be not able to cure everything, but we must never forget to take care. Next. Caring should be the medicine default mode. As our beloved Pellegrino said, for the first time, we can heal without care. And we are going to be able to heal without care. But the experience of being healed is ontologically linked to the being cared for. So it's for me, the first lesson of COVID is don't forget to care. Next. And also our society. I think one of the illusions of this kind of therapy could bring to a society is the illusion we are going to be able to cure everything, but as Richard Sennett say, a society that provides people with no deep reason to care for each other can no longer preserve its legitimacy. I think first lesson is don't forget to care. Second, training of healthcare professionals must incorporate a strong ethical training. Next. Why? Because without ethics, we are as computers of IA algorithms. If a physician can be replaced by a computer, then he or she deserves to be replaced by a computer. And ethical abilities, ethical skills, ethical knowledge, it's the difference between us and a machine. Next. Next. So ethics training, ethics as a content, and also ethics as a method. Next. Ethics as a content with a strong ethics foundation and ethics systems, solid professional values, and also communication. And as a method, why we need a method? Because our society is complex, changing, and liquid. So we need to provide professionals with a strong values for a liquid society. And the third lesson, we must talk more about relational autonomy. We should talk more about relational autonomy than autonomy. Next. Why? Because the dominant characteristic of autonomy seems to be developed in a social and cultural vacuum. However, human beings are living in a society with a lot of relationships. So I think first bioethic revolution was autonomy. The second bioethic revolution must be relational autonomy. Next. So it's the last one. I think it's very useful to talk about how high tech, but we also must talk about high touch. There's no high tech without high touch. That's what I finally learned about COVID-19. And high touch, it's the ethics competence, the communication competence, and all the competence related to be able to bring all of that, all of the genetic edition, or the genetic therapy to the practice, and it's that could link both of the paradigm, the balance between a humanly scientific, a scientifically human medicine. Thank you very much.
You can try. Okay, so our next speaker is Emanuele Cozzi. He comes from University of Padua, Italy. Since January 2020, he is a full professor at the University of Padua. In September 2001, he joined the Padua Medical Center, where he directs the Transplantation Immunology Unit of the Padua University Hospital. From 1993 until 2001, he has worked as a clinical research associate in the Department of Surgery of the University of Cambridge, UK, where he contributed to both clinical and preclinical activities in the field of solid organ transplantation. From 1988 until 1991, he has worked as a research fellow in the Department of Microbiology, New York Medical College, Valhalla, USA, where he was mainly involved in clinical trials regarding the use of monoclonal antibodies in autoimmune diseases. In 2000, he obtained a PhD from the University of Cambridge, UK. In 1991, he obtained his specialization in geriatrics at the University of Padua. In 1987, he obtained his specialization as an allergist and clinical immunologist at the Padua University. Professor Cozzi has published extensively in the field of transplantation and is author of more than 200 manuscripts in international journals. His area of expertise encompasses clinical transplantation immunology with particular regard to humoral rejection and research in the field of solid organ and neural cell transplantation. And his talk will be about COVID-19 and vaccines. What did we learn?
Thank you. Oh, okay. Thank you very much, Dr. Borovecki. I will try to use the pointer, yeah? Yeah, it's not working. I don't know if the battery, sorry? Oh. Okay, so I should, okay. So yes, I am a transplant physician, and I've been involved in the COVID-19 pandemic because, as you all know, Italy was the first country hit in Europe and in the world after China by COVID. So we found ourselves really very stuck. And I am dealing with transplantation where our patients are immunosuppressed. So basically there was a pandemic that was going to explode, and we were dealing with very vulnerable patients. So I was immediately kind of obliged to have a look into that, and these are consultancy that I have for the pharmaceutical industry in transplantation, so I don't have any really conflict. Okay, so basically there are different points which I will not touch all of them, but I will mention the ethical consideration that were really related to the COVID-19. So there was a desperate need of trying to find a solution for our patients, and we were ready, of course, to take under consideration other approaches with side effects, okay, due to the serious situation that we were facing, okay. And clearly from an ethical standpoint, it is fundamental that whatever we have to offer should be available to everybody, and to everybody doesn't mean to all the Italians, it means to everybody globally. There are obviously, from an ethical standpoint, costs issues to deal with, and then there are some aspects that we have to consider, and I think that people do not often take this into consideration, that we have to protect not just ourselves with vaccines, but also those patients who will not be able to benefit from vaccine themselves. As you know, for instance, there are children that cannot be exposed today to conventional vaccines, so even more so they will not react to and get a favorable immune response towards possible infection. Okay, and then of course immunosuppressed patients like the one we are dealing with are an example. Of course, we want really to make sure that we have a fast access to patients. And in some cases, as you will see, vaccines will go into many, based only into some very preliminary preclinical data. And then there is the concept of hesitancy. Okay, so this is a slide which is early on in the pandemia, okay, and we are, these are Italian data from the Italian NIH, and the concern here is only look at the age of the people, 60 to 69 age, years, which is my age, and as you see, the mortality is 6.8%. This is the sort of mortality we were having in Italy at the beginning of the pandemic when it hit Europe. Okay, so the mortality was tremendously high. So we had really nothing. So you understand, we were really desperate and ready to do anything. And we were, as I said, opening the ground to everybody. Now, this slide is a recent slide, which is obviously of concern and certainly raised some ethical concerns indeed, because we are talking about a slide which is updated at July 2022, so just under 2 months ago. And what we see is that in the Western countries, okay, 7 to 80 or plus % of the patients have been vaccinated, but only look at the center of the picture, and as you see in Africa, we have only 15% of the patients who have had access to vaccines. And this is a major concern. A major concern for many reasons. First, of course, for ethical reasons, but also because most of us have to remember that most of the variant of concern, okay, they do come from countries that are not as fortunate as we are, okay? And as you know, the Omicron variant indeed started from South Africa, Botswana, and South Africa. So really this has to make us think about vaccine also in terms of making sure that we have access. Yeah, next slide, because I don't think it's, okay. Okay, this is another slide which is very important, okay? And it's a paper that has been published just a month ago, but it is very important because it shows us, okay, these are statistical investigations, but they are very clear, and I speak from themselves, okay? And they show the COVID-19 deaths that were avoided, that thanks to the vaccination. And the data are incredible. But I just want to bring to your attention to the right, to the part B of the picture. And these are the deaths averted per vaccination per day. And if you see in violet, okay, these are obviously the high-income countries. But if you look at in yellow, so you see that a lot of deaths are estimated to have been avoided thanks to vaccines. And we all know that because the mortality in Italy has dropped in my age range from 7% to under 1%. So we know that this has been tremendously a strong outcome of the vaccines we have had access. But the worrying thing is that if you look at the 1-year follow-up since vaccines have been made available, I have circled in red, okay, the low-income countries. That should be the yellow area. And that basically, okay, there were no deaths averted thanks to the vaccine. And that should really raise some concern as to whether what's going on there. Okay, next one, please. Okay, and here you see the estimate. I mean, they are really tremendously. And as you see, the findings is that they say based on officially reported COVID-19 deaths. So these are deaths we are sure. I mean, they estimate that vaccination prevented 14 million deaths from COVID in 185 countries. Okay, so that really make us think how incredible the vaccines were. And the interpretation is that, okay, vaccination has substantially altered the course of the pandemic, saving tens of millions of lives. However, inadequate access to vaccine in low-income countries has limited the potential benefit from vaccine. And that really should encourage us to think about it. The next one, please. Okay. The structure of the virion, just a couple of very quick immunological pieces of information that will allow you a bit better to understand what I'm doing. We move on. Yes, so basically, all the vaccines, for you to know, they were directed against the so-called spike glycoprotein, okay? And the spike, next one, please. The spike glycoprotein expressed on the virion is the protein that enabled the virus to anchor to the cells. Okay? Next slide. And as you see in the immune response, I mean, the area in red there, okay, that the virus, there is no hand microphone, no. Non c'è un microfono portatile perché così faccio capire meglio. Grazie. I think it will be more beneficial to you if I just show you. Thank you. So basically what it wants to show us is that the virus will anchor the cells. Now, if the anchor is covered by an antibody, okay, the anchor will prevent the virus to enter the cells. So that's the point number one, we need antibody. Next slide, thank you. And the second thing, which is as important, what happens once the cell is indeed invaded by the virus? What's happening? What we really need to do is that the cell at that stage become a factory of viruses. We really want the cells to be killed. And what we need, these are the cytotoxic T cells. So these are lymphocytes, these are, as you would say, white blood cells that will have to kill the cells. So to have an efficient immune response, that's a critical slide. To have an efficient immune response, either from a natural immune suppression or from a vaccine-induced immunosuppression, you need both bits. You need to make sure that, first of all, you try to prevent the anchoring of the virus to the cell, and if there is no antibody that prevents it, you really need to make sure that you are going to destroy the cells. So you understand that any vaccine that will have to be used will need to have both activities. Otherwise, it's going to be a disaster. It's not going to work. And let me tell you that in most cases, it works well. Next, please. OK, so we said we need antibodies, but we need also T cells. Very important. Next one, please. So this is a slide that clearly shows us that if you look at the outcome, and here the key variable is age, okay? What happens with age is that, as I said, to get rid of the infection, you need the cytotoxic T cells and you need the antibodies. You need both. If you are young, you have both, and you certainly will be able to get rid of the infection. But as ages goes up, or if you take immunosuppression because you do have a transplant as the patients I follow, or because you have to take drugs, like anti-cancer drugs, what happens is that the immunosuppression will no longer be able to rely on a fully competent immune system that produces antibodies and produces cells, okay? So what happens is that you don't get rid of your infection. So what does it mean? That we had patients with thousands of antibodies, incredibly high numbers of antibody, who did not make it because they didn't have the cells. See what I mean? So that was prior to the infection. So we knew that, to have just antibody. And people speak a lot. In my view, they even speak too much because they speak about antibodies. Okay, that's not enough. Next one, please. Okay. And as you see here, this is a paper published 2 months ago on the New England Journal of Medicine, which is the most important medical journal for us. Okay. And what it shows, it's something which I was just telling you. To get rid of infection, you need of antibodies and T cells. And as you see, as time goes by, okay, you have a greater impact of the cells. Why? Because the virus is already into your cells that enable the virus to replicate, multiply, and impact on other organs. So it will be critical when we will be studying the immune response to the virus to show not only antibodies, but T cells. Next, please. Okay, so very quickly, to produce vaccine, there are 7 strategies. I have only circled the one that are certainly allowed in Europe and in the United States. We don't go into the details. Just something very quick. Next, please. Yeah, because some of them we've spoken about the so-called mRNA vaccines. Okay, and these are bits of RNA which are included in lipid particles. And this, why am I saying that? Because this is something very important, that if you don't protect the RNA, okay, the RNA will be immediately removed from the blood, okay? And in order to do that, okay, you have a major limitation, that these vaccines require a storage at -70 degrees. So what does it mean? That clearly this vaccine will not be accessible to people in Africa. okay? They were, prior to the pandemic, already in a difficult situation. We won't be able to provide them vaccine that need a storage of -70. Let's move on. Okay, and yeah, just to show you, once the RNA is in, okay, it doesn't matter, but somehow there is a protein that will be presented to the immune system, and the immune system will either produce antibody or a B cell response, okay? So you inject RNA, fundamental in a bubble of fat, okay, that needs to be injected. The immune system will recognize the protein as non-self, and it will therefore elicit an immune response. Prossima, grazie. Okay, a different vector is adenovirus-based vaccines. And I only here, I don't want to go into the details, but for you to know, the adenovirus, okay, these are viruses that do not require cold storage, -70. So big advantages. So this will be the vaccine we will be possibly able to administer to patients, to subject and to population that are not as wealthy as Western countries. Let's go on, okay? And okay, we can move on, yeah. And then that is the third technology which is very much in use. So basically, in vitro, so it means in the lab, we produce proteins. Which proteins? The spike protein, okay? So in the lab, we produce a large amount of spike protein, and then what we do, I don't want to go into the details, but then the protein, we inject it in the patient, in the subject, okay? So that is going to be an immune response against a foreign antigen, like, for instance, the vaccine that we use, for instance, for tetanus, okay? We move on, thank you. So the important thing, this slide is from the beginning of the year, but it's only want to give you what's going on here, is that at the beginning of the year, there were more than 300 COVID vaccines that were being tested, from preclinical study to various phases, and also 23 vaccines were already in clinical use. So that's clearly a field which is rapidly moving, okay? For you to know, I have spoken with someone who is in the vaccine industry, and he told me prior to the pandemic, altogether, for all the vaccine we were doing, especially in children, but anything from yellow fever or whatever, okay, we were producing roughly 5 billion doses of vaccine every year, okay? And he told me, since we are in the COVID vaccine production, from 5.5 billion doses per year, we are now producing 11, 12 billion doses per year. So you understand of how this has dramatically changed the whole situation from in every respect, so including the pharmaceutical industry that had to, of course, invest a lot of money. Let's move on. Vaccine efficacy. Move on. Okay. Very quickly, this is one of the very key studies. These were 1.2 million Israel subjects that were either receiving a vaccine or they were used as control. And as you see already, immediately, 15 days after the second dose or after the infection, you have a dramatically reduction of the incidence of either infection or symptomatic cases. So the results became very clearly in favor of the vaccine. Let's move on, please. Yeah, and it also showed that, I don't want to go into the details, but the vaccine that we use for mRNA, usually you used to require 2 doses, but this was clearly showing that 1 dose was already sufficient to wake up the immune system. What does it mean? It means that we had no doses for everybody. And one country, the United Kingdom, decided they would be postponing the second dose to enable a larger immunization of a larger part of the population. And that was correct. It was only shown very significantly in the New England a year later, but that was the right decision. Let's move on. Okay, now, as we said, vaccine efficacy requires involvement not just of B cell that produce antibody, but you need the T cells. And also, there are possible limitations. And as you all know, the vaccine efficacy doesn't last forever, but more importantly, there are new variants. Okay, so you may have a vaccine against variant A. Let's see if it works for variant B. Let's move on. Thank you. Okay, and this clearly show, okay, that certainly following different vaccines, these are different tests. What it wants to show you is that definitely, irrespective of the 3 vaccines that you use, you will have the production of antibody. That will, however, decline with time. And how it will decline? Very quickly, after 6 months. This is a semi-logarithmic scale, as you know. The number drops dramatically from 700 to 262, 1,800 to 500. So the antibody go down very quickly. But we said not just antibody. Let's move on, please. Okay, and that is very encouraging, because these are the cellular immune response. We said once you have contracted the infection, you need to get rid of infected cells. And who is going to do that? The T cell. And the important thing is that all the vaccine, they produce a cellular immune response, which is very encouraging. But prior to showing this, and these are data that were 1 year after the initiation of the clinical trials, we could see that all the vaccine, the key vaccine used, were indeed eliciting not just antibody, but also a T cell immune response, which is important. And very encouraging, the T cell response, not the antibody response that declines very quickly, in the data that exists, the T cell response seemed to last fairly longer than the antibody response. But we have a problem. Which one? Of course, the variant of concern. Because we were started with the Wuhan, and today we are with the Omicron, and not just the Omicron, the BA5. So as you understand, we ask our immune system to recognize new variants. Okay, let's move on. Thank you. Okay, as I said before, greater durability of T cells compared with antibody. That drops very quickly. Move on, thank you. Okay, let's move on. Okay, so that's want to show you what's going on. So basically, in this study, okay, we could see that there was an efficacy of 96%, so protection which is extraordinary. But look what happened after just 2 months. It drops dramatically, okay? And as you see, the protection, so this is the clinical data, not a laboratory data, okay, it dramatically goes down, and 4 months after the second dose, the efficacy of the vaccine in terms of protection of infection goes down dramatically. So clearly we found ourselves in a situation where what seemed to be very promising is not long-lasting. Next one, please. Okay, let's move on. That's another study that was nonetheless adding something encouraging. It is true that you have a reduction of antibodies that is associated with infection. It is true, but, and we are here at 4 to 5 months, but the important thing, and we have seen this in all the hospitals in the world, including Padova, okay, is that although the antibody was going down and you were getting reinfected, the hospital admission, the admission in the intensive care, and the death of our patients were dramatically reducing themselves. Okay, so the important thing is, I hear people saying, oh, what's the matter of doing the vaccine since there are a lot of so-called breakthrough infections? Well, the answer is here. You may get a breakthrough infection, but you will not be admitted in the hospital, in the intensive care unit, and if you have my age, possibly also, you would lose your life. Okay, so those who are hesitant, let's see what hesitancy we are talking about. Move on, please. Thank you. Other problem, variants of concern. Let's move on. It is clear that the immune system, okay, was originally ready for this variant, which is the Wuhan variant, but then we had a lot of different variants. And the variants, what does it mean? That the protein that the immune system must recognize is no longer the one that the Wuhan protein was presenting. And as an example, as you can see here, we are talking about the Omicron in June 2020. Just one protein, which is the protein spike I showed you initially, there are 50 mutations, 50 mutations, just in one protein. So what happens? The protein spike is the one against which I ask an immune response, but it's no longer the same protein spike as I was supposed to have. Okay? Let's move on. Thank you. So, okay. So having said so, as you see here, okay, if you have a vaccine that was designed against that protein spike that belongs to the variants of Wuhan, as you see, as we get to the follow-up variant of concern, the power of the efficacy of the virus will change. So two problems. Number one, the immune response is not forever. Second problem, we also have to deal with an immune response that has now to catch another virus. Let's move on, please. Thank you. Okay, so the same thing applies for the T cells, but perhaps, fortunately, it's not as severe. Let's move on. Thank you. Okay, now, here, the thing that is of concern is that basically we are looking at the response, okay, against the Omicron. BA1, BA2. We're not having at the moment in Italy and in Western countries the BA1, BA2. As you have seen, we have primarily BA5, okay? Now, what we see here is that following the infection, the vaccine, you have the production of antibody against the variant of Wuhan. That was the variant that has been used until 2 months ago in all the vaccines. We have been vaccinating our people, okay, using the variant of Wuhan antigen, okay? But as you see, there was no proper good immune response against the new Omicron variant, which is not strange. What is strange, though, is that after the booster, so 2 injection, as most of us have done, after the booster, 3rd injection, for some reason, we were fortunate to notice that we have indeed an immune response, not as good as against the Wuhan variant, but we have the immune response that somehow now recognize also a subsequent variant, okay? So what does it mean? It's not perfect, but it looks like the immune system, for some reason, okay, is able to fill in somehow some of the gaps. Let's move on. Okay, so now, having said so, it's not as easy as we were hoping. And these are samples from patients, okay, who were receiving a vaccine against Wuhan. We said all the vaccines were against the Wuhan variant, not the latest one, okay? And what we see, that if you have a good response, you will have a good response against the Wuhan, okay, which is expected, and it will progressively go down. But the latest versions, which are the variant we are facing today, okay, this vaccine have little effect, okay, in terms of neutralization. And even if you get infected by an early, so these are data that regarded people infected by an early Omicron variant, which was at the beginning of this year, okay, even if you get infected with an Omicron variant at the beginning of this year, your immune system does not work well with the Omicron which is circulating now in Europe and in the United States. I mean, just to tell you, in the Western countries, okay? Now, tomorrow things may change, but at the moment, someone who has been injected and had also the infection, okay, the infection does not seem to recognize the latest variant, which we said we shouldn't be entirely surprised, because the latest variants are associated with mutation of the proteins that should be recognized by the immune system. Let's move on. Okay. How many minutes do I have? 1 minute? Okay, let's move on. So let's move on. Yeah. Okay, I think we should move on. Okay, so now, just a concept. The concept is the following one. If instead of giving another dose from the same vaccine, okay, if you do another dose from another vaccine, the efficiency is better. Let's move on. Okay, move on. But that's a concept. So if the immune system is exposed to different vaccine, it will work better. Let's move on. Move on. I only want to take you to another point. Yeah, move on. Safety aspect. That was the last point I wanted to touch on. Okay, myocarditis. Okay, let's move on. So we know that these vaccines, okay, may lead to some, let's move on, to some side effects, okay? And the next slide, thank you. Okay, the important thing is here, okay, that we are planning, and that has an ethical also dimension. We are planning to inject patients who are young individuals. And we know that these, okay, may be the category with the risk for myocarditis. And there are 10 reported deaths in young men as a consequence of vaccine. Let's move on. Okay. Another thing is the thrombosis. Also, the vaccines may lead to thrombosis. Let's move on. Okay, let's move on. Okay, pregnancies. At the moment, let's move on. New England Journal of Medicine, the risk of having miscarriages in the first trimester is not increased. Let's move on. Andiamo avanti. Okay, children. Okay. This slide was only to show you the next one, okay, that the people who will, okay, be in hospital for COVID, the children, will be primarily those who are not vaccinated, okay, and access to intensive care or discharge or death in the hospital are children who are not vaccinated. Let's move on. Andiamo avanti. Ok, andiamo avanti, il concetto è lo stesso. Ok, we said it, andiamo avanti. Okay, last point. We are now proposing a new vaccine that is available already in Italy, and it's also approved by the United States. The important thing is that this is a science journal, okay? And the important thing is that we do have a lot of questions on the new vaccine. Let's move on, okay? Just a couple I will show you, okay, is that, for instance, for the booster with the latest variant of the vaccine, the data that have been submitted by company for approval have only been generated in animals. Okay, so at the moment, we have serious concern. Probably it's going to be the way out, but we must be careful. Let's move on. So this is a slide of the last month. Well, the last month, yeah. Andiamo all'ultima, perfetto. Conclusion. Okay, so an efficient immune response, as I said, requires both production of antibodies and T cells, okay? And antibodies are not everything. That's the important thing. You may have very high antibody and you may die. And those who have no antibody, who will survive? There are different technologies. There are limitations, as I said, with the vaccine we are using today. But altogether, the efficacy studies do show really a tremendous efficacy. It will not last for as long as we would like, but it does work, okay? And of course, there are still many ethical issues that need to be addressed, and the first one, at least for me, is to enable access to these vaccines also to low-income countries. Thank you for your attention.
Okay. Okay, this will conclude our session. As we have run out of time, we will have no questions, but if you have additional questions, please send us these questions via internet, and we will try to respond to the questions. So thank you for your attention.